Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you for listening today. We're going to keep on with the top 200 drugs. We've got 171 through 175. First medication is Sandimmune. That is a brand name medication. Cyclosporine is actually the generic name. It's probably the one I hear more often. This is an immunosuppressive type agent. It is classified as a calcineurin inhibitor. So basically, calcineurin inhibitors, tacrolimus being the other medication, these essentially work to suppress the immune system, and they do that by inhibiting the action of calcineurin, which is a protein phosphatase involved in activating T cells. Remember, T cells play an important role in the immune system, and basically attacking viruses and bacteria and different foreign objects basically to the body. So they play a critical role in those immune responses. So ultimately, what you could imagine this medication is used for is immunosuppressive purposes. So the primary use is going to be in patients who have transplants. So any type of kind of organ transplant, often cyclosporine will be a part of their medication regimen, and that's, again, to kind of prevent the body's own immune system from attacking that organ. A few things to note. There are different brand names as well. Neoral, Gengraph. These should not be substituted. That's kind of a note, probably more so for pharmacists specifically. But if you see a different dosage form being switched, so Sandimmune to Gengraph, for example, these are not interchangeable. They are not bioequivalent, okay? So, if you give the same dose of one versus the other, doesn't necessarily mean that that similar amount that you need to keep those levels steady is going to be absorbed for that patient. So, need to be really, really careful. Obviously, in most of these situations, there's a boxed warning about using this medication if you're not an experienced healthcare professional. So that's a really important thing to note there as well. From the adverse effect standpoint, obviously the first thing to think about is whenever we suppress the immune system, we got to think about infections and malignancy. So that's first and foremost what we're paying attention to. In a transplant situation, we're typically not going to be able to just discontinue the drug. If a patient runs into, let's say an infection, for example, that's probably not something we can do. We may adjust the dose, adjust levels, and may just have to work with that. But again, we basically can't stop the drug because, we're going to have rejection of that organ likely. Obviously, unless we have another plan in place to switch to something different. Other kind of unique adverse effects, hyperglycemia can happen. So, increased risk for diabetes and exacerbating diabetes if a patient already has it. Hyperkalemia, so elevations in potassium, can also raise blood pressure. So, kind of from a cardiovascular standpoint, there may be some concerns there. Also risk for nephrotoxicity, neurotoxicity, also drug-induced gingival hyperplasia, or overgrowth, essentially, of that tissue. So how do we try to minimize those risks of those adverse effects? Well, certainly we monitor and track drug levels, and that target drug level can vary. And that's typically going to be based upon how far beyond the transplant a patient is. And typically the further you get from when that transplant happened, we can generally back off the dose. Again, can vary depending upon certain circumstances and all that sort of stuff, but generally the further you are out from the transplant, typically patients, we can get those drug levels lower and potentially reduce doses. Again, not all the time, but that can vary a little bit there. That's typically how it's going to be done. Finishing up with drug interactions, this is probably one of the things that I think about most. I wouldn't classify myself as one of those experienced providers that works in a transplant unit. But what I do know is cyclosporine has a lot of drug interactions. And if we're causing fluctuating dosages of cyclosporine, that's an issue. That's going to be an issue for either transplant rejection or increase their risk of toxicities and infections and things like that. So this is probably my most important take-home on this, is pay attention to new medications. So CYP3A4 inhibitors can increase concentrations, and any type of CYP3A4 inducer can reduce concentrations. Okay, very, very important to remember that. I think I've talked extensively about CYP3A4 inducers and inhibitors previously. Go back to previous episodes, or look up a list yourself if you want more info on that. But very, very important to remember that CYP3A4 is very, very important with this medication. One, I guess, food diet issue that you might not catch as a healthcare professional if you don't specifically ask is grapefruit juice. So if you got a patient with very fluctuating levels, remember that grapefruit juice, that is a CYP3A4 inhibitor, which can raise concentration. So if you got a patient taking grapefruit juice, once every third day, or maybe on the weekend or something like that, that could really throw those levels for a loop a little bit. So pay attention to that. The other drug interactions I think about are some of the additive effects, to hypertension or diabetes or, nephrotoxicity risk. So say you need to use, vancomycin or gentamicin or something like that for an infection, that nephrotoxicity risk could go up. Moving on, we've got medication 172. This is insulin glargine, brand name Lantus. This is a long-acting insulin, or otherwise called a basal insulin. It's going to be sub-Q injection, typically given once a day. There are rare occasions where I've maybe seen it given twice a day, but again, most patients are going to be able to get by with once a day. Keep in mind, insulin, mechanistically, it causes that intracellular shift of glucose out of the bloodstream into the cells. So that's what's helping us lower blood sugar in the management of diabetes, which is what this would be used for. So ultimately, we're tracking A1C, monitoring that, making sure that we get that to our desired goal. Adverse drug reactions, it's an insulin product, so hypoglycemia, low blood sugar, kind of a no-brainer. Weight gain as well. Hypokalemia, so elevations in potassium, is listed as an adverse effect. Now, when we're talking about kind of low, long-acting, consistent dosages, generally not something I worry about too much compared to giving IV rapid-acting insulin or something that's used for the treatment of hyperkalemia. It's going to bring that potassium down quickly. Okay, so long-acting insulin, generally, I'm not going to worry about it too much as causing low potassium levels. It's more kind of the acute rapid-acting insulins that might do that abruptly there. The initial dosing I did want to mention, it's 10 units for patients with type 2 diabetes. Insulin dosing for type 1 varies for sure. Titration, again, I'm focusing more so on type 2, which is way more common in my patient population. That dose titration is in the 10 to 20% range typically. I would say in practice, most patients, what I'm going to see is a 2 to 3 unit change. So let's say somebody's A1C is elevated, blood sugars are up, those fastings are, 150, 170, 190. They're definitely higher than we would like. In those type of situations, you'll probably see a bump of 2 to 3 units. Again, if you got a patient on very, very high dosages, maybe that's a little bit higher, but that's kind of the standard practice, and where most clinicians are going to start to increase that insulin glargine if they feel it's necessary to do so. Adverse effect profile. One last thing I did want to mention is with kind of administration. You can have some injection site issues. So, make sure we're rotating sites, using different sites when we're giving that insulin consistently. Drug interaction standpoint, additive effects. I always think about other medications that lower blood sugar. It's going to increase the risk for hypoglycemia. Your SGLT2 inhibitors, GLP-1s, metformins, anything used for diabetes management is going to increase that risk for hypoglycemia when we use a medication like Lantus. Sulfonylureas are particularly bad, or maybe bad's not a great term for it, but I don't love sulfonylureas with insulin products. I think you probably get a little bit more sporadic insulin release as far as the way sulfonylureas work. So, I generally discourage that, and I think the guidelines are leaning that way as well. Recently just did a blog post on sulfonylurea use and insulin being used together. That's at meded101.com, so if you want to Google search that, and meded101.com, you should see it. Sulfonylureas and insulin together. Definitely a good little review there of why it's kind of challenging and maybe not the greatest thing to use, and contributes to my least favorite, which is polypharmacy as well. Drug interaction standpoint, I think about the flip side of it too. So you got the hypoglycemia, which I just discussed. Can also have medications that counteract the effects of insulin. Corticosteroids being kind of the classic example of a medication that can cause hyperglycemia and try to oppose the beneficial effects of utilizing insulin. Next medication is Cialis. Generic name is Tadalafil. This is a medication used for erectile dysfunction. May also see it used for pulmonary hypertension. Rarely, I have seen it used for BPH as well. Mechanistically and classification, this is what's called a PDE5 inhibitor. So mechanistically, by inhibiting phosphodiesterase 5, that's the PDE5, we increase levels of cyclic GMP, and this causes smooth muscle relaxation and can increase blood flow to the penis, for example, for erectile dysfunction. With that, knowing that mechanism and kind of that smooth muscle relaxation, we can have a drop in blood pressure. So that's probably one of the biggest things I worry about, particularly if we're talking about maybe older patients, above 60, above 70, that type of thing. Got to pay attention to that. Make sure we're not, increasing fall risk, for example. Rarely, there's been some changes in vision color as potential adverse effect there as well. From a drug interaction standpoint, any medication that can lower blood pressure can have some additive effects there. So, kind of monitor that closely. I think of a situation like BPH, if this medication happens to be used, that can, lower that blood pressure further, obviously. And oftentimes in BPH, we use alpha blockers as well, such as tamsulosin, or maybe even worse on that blood pressure lowering effect, maybe a non-selective alpha blocker like tirazosin, for example. So, again, pay attention to that. Pay attention to blood pressure, dizziness, falls, all that, all those kind of adverse effects. And then last, obviously, this is probably one of the most highly testable board exam questions that you're going to get. I've seen it numerous times myself, that nitrate interaction. So, avoid using, nitroglycerin, nitro-type products with a medication like Tadalafil, and you can cause some profound drop in blood pressure, lead to a syncope type event there. For Tadalafil specifically, it does have a longer half-life than some of the other ones, so it's recommended to avoid nitrate use for 48 hours with that medication, compared to like sildenafil, which is a little shorter window of avoiding nitrates, like 24 hours. I just talked about that nitrate interaction. Again, really, really important board exam question. If you're looking for study materials for board exams, you're a pharmacist, go check out med101.com/store. We've got a growing list of resources, NAPLEX content, BCPS, ambulatory care, geriatrics, BCMTMS, all those different exams. Got comprehensive packages, and we've helped thousands of pharmacists prepare and pass their board exams. So go check that out. Support the sponsor, med101.com/store. Your purchases there go directly to help support this podcast. All right, so the next medication I want to mention is amitriptyline. Brand name is Elavil. This is a tricyclic antidepressant. It increases the synaptic concentration of serotonin and also has some norepinephrine increasing effects as well. So the way I think of tricyclic antidepressants is probably similar to an SNRI. So that would be like duloxetine, for example, where we've got that serotonin and potentially norepinephrine effect. Also, with TCAs, you got to add in that there's anticholinergic activity. So much, much more anticholinergic activity than the SNRIs, which generally don't affect those receptors. Uses for a medication like amitriptyline, I see insomnia, I see neuropathy, fibromyalgia, other pain syndromes, occasionally depression. Those are probably the main indications I see it utilized for. Again, the adverse effect profile, we generally don't like to use these. If it's in a younger patient, it's probably okay or a little bit better tolerated. Older patients, we run into those adverse drug reactions with those anticholinergic effects. So particularly amitriptyline is not great as far as that goes. So highly anticholinergic, dry eyes, dry mouth, constipation, you can increase fall risk. They're very sedating as well. You'll probably most often see these dosed at night. So let's say you've got a patient with insomnia and fibromyalgia. Like that might be a situation where you see this medication utilized to help with something like that. Also of note, in depression, there's a risk of cardiac issues, QTc prolongation, and one of probably the bigger concern in somebody who's suicidal or suicidal ideations, that overdose risk with a medication like this generally tends to be greater with amitriptyline and that cardiac risk compared to some of the, I guess, relatively newer agents in the SSRIs. They've been around for quite some time too, but amitriptyline is older than those. So that's kind of one, two, three reasons why amitriptyline has fallen out of favor for the management of depression compared to other agents. Another adverse effect I did want to mention was sexual dysfunction. That can definitely be an issue there. And then drug interactions, serotonergic drugs, we can have kind of that additive effect. With MAOIs, we want to avoid. And then the additive anticholinergic adverse effects are something that I think about, something I review, and an issue I run into probably on a daily basis in my geriatric practice. So other medications with those additive anticholinergic effects, you've got some antipsychotics that can have anticholinergic activity. I think of some of the medications used for urinary symptoms, such as like oxybutynin, for example. This can have significant additive effects to that. Also, some of the older antihistamines that might be available over the counter, like diphenhydramine, for example. We're going to make the dry eyes worse, the confusion worse, dry mouth, constipation, urinary retention, and so on and so forth. All right, last medication, number 175, is Gemfibrozil. Brand name is Lopid. Used to see this medication utilized much more than it is now. Probably a couple of reasons for that. One reason is it is twice daily dosing. It is a pretty big pill as well, so that can be, annoying, problematic for patients. And then we've got some drug interactions too that aren't that great. So, kind of numerous reasons why this medication isn't utilized too much. The primary reason you're going to see it used is elevated triglycerides. With that said, probably the preferred agent, if we're just targeting triglycerides, is fenofibrate compared to Gemfibrozil. Again, a little less on the drug interactions, maybe a little bit more tolerable, and a little less frequent dosing potentially there. Mechanistically, how it lowers triglycerides isn't that well understood, actually. And then administration-wise, I mentioned that BID dosing. It's probably ideal to give before food, as food decreases absorption by up to 30%. And so that can be a potential concern there with drug concentrations and how well the drug is working. Now, the challenge, the flip side of that, giving it a little bit before eating, is there is a significant percentage, maybe up to 20% of GI upset with this medication. And so, again, another kind of knock on it, another reason why this medication's kind of fallen out of favor compared to a medication like fenofibrate, for example. One last rare adverse effect I guess I'll mention is some associations with hepatotoxicity. Now, drug interactions I want to mention. Probably the biggest thing, patients who have cholesterol issues are often already on statins. Using Gemfibrozil in combination with statins can increase the risk for rhabdomyolysis. So this can be fairly significant and definitely something to be aware of for sure. The other interaction, I wouldn't call it crazy severe, but something to be aware of, CYP2C8. So it isn't an incredibly common enzyme as far as breaking down medications, but Gemfibrozil inhibits CYP2C8. And probably the two most notable medications I know of that are broken down by CYP2C8 are amiodarone and pioglitazone. So amiodarone being an antiarrhythmic type medication, and pioglitazone can be utilized for diabetes. Don't see as much as I used to, but both of those medications can have their concentrations increased by the action of fenofibrate. That's going to wrap up the podcast for today. Take advantage of the free 31-page PDF on the top 200 drugs. Simply in the email, we'll get you access to that at reallifepharmacology.com. So go sign up, do that. Leave a rating, review on iTunes or wherever you're listening. Go check out all the Amazon books, study materials, lots of different content, no matter what you're doing, whether you're a nurse, pharmacist, med student, so on and so forth, pharmacy technician. meded101.com/store has tons of resources that have literally helped thousands of healthcare professionals. So go support the sponsor, meded101.com/store. Help support this podcast and also help grow this podcast as well. If you have friends, colleagues, students, please share this podcast. Let them know this is available. Try to help them learn, understand pharmacology better, and ultimately help improve the lives of our patients for sure. So with that said, if you want to reach out to me, mededucation101@gmail.com. Otherwise, you can connect with me on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. I'm going to sign off for today. Thank you so much for listening. Have a great rest of your day.